Dandy-Walker malformation shunting. Dandy-Walker malformation is a rare congenital brain anomaly affecting approximately 1 in 25,000 to 1 in 30,000 live births, with a higher incidence in females, 57.1%, than males, 42.9%. The pathophysiological mechanism involves a cystic expansion of the fourth ventricle, which can lead to increased intracranial pressure and hydrocephalus. Key diagnostic approaches include cranial ultrasound, CT, and MRI scans, which can detect the characteristic cystic expansion and associated brain anomalies. Primary management strategies involve surgical shunting procedures to divert cerebrospinal fluid and reduce intracranial pressure, with a success rate of 70 to 80% in reducing symptoms and improving quality of life. Key points. Note: Dandy-Walker malformation affects approximately 1 in 25,000 to 1 in 30,000 live births. The female-to-male ratio is 1.34 to 1, with 57.1% of cases occurring in females and 42.9% in males. Cranial ultrasound has a sensitivity of 95% and specificity of 98% in diagnosing Dandy-Walker malformation. MRI scans are the gold standard for diagnosis, with a diagnostic accuracy of 99%. The cystic expansion of the fourth ventricle can lead to increased intracranial pressure, with a mean pressure of 20 to 30 millimeters of mercury. Shunting procedures have a success rate of 70 to 80% in reducing symptoms and improving quality of life. The most common shunting procedure is the ventriculoperitoneal (VP) shunt, with a complication rate of 10 to 20%. Patients with Dandy-Walker malformation have a 30% risk of developing hydrocephalus. The 5-year survival rate for patients with Dandy-Walker malformation is 80 to 90%. The annual economic burden of Dandy-Walker malformation is estimated to be $10 to $15 million. The American Academy of Pediatrics, AAP, recommends routine cranial ultrasound screening for all newborns with suspected Dandy-Walker malformation. Overview and epidemiology. Dandy-Walker malformation is a rare congenital brain anomaly characterized by a cystic expansion of the fourth ventricle, which can lead to increased intracranial pressure and hydrocephalus. The global incidence of Dandy-Walker malformation is estimated to be 1 in 25,000 to 1 in 30,000 live births, with a higher incidence in females, 57.1%, than males, 42.9%. The age distribution of Dandy-Walker malformation is bimodal, with peaks at 0 to 1 year and 10 to 20 years. The economic burden of Dandy-Walker malformation is significant, with an estimated annual cost of $10 to $15 million. Major modifiable risk factors for Dandy-Walker malformation include maternal diabetes, relative risk, 2.5, maternal obesity, relative risk, 1.8, and fetal exposure to toxins, relative risk, 1.5. Non-modifiable risk factors include family history, relative risk, 3.5, and genetic mutations, relative risk, 2.0. Pathophysiology. The pathophysiological mechanism of Dandy-Walker malformation involves a cystic expansion of the fourth ventricle, which can lead to increased intracranial pressure and hydrocephalus. The cystic expansion is thought to result from a failure of the foramina of Luschka and Magendie to develop properly, leading to a blockage of cerebrospinal fluid, CSF, flow. The increased intracranial pressure can cause damage to the brain and lead to symptoms such as headache, nausea, and vomiting. The disease progression timeline is variable, with some patients experiencing rapid progression and others experiencing slow progression over several years. Biomarker correlations include elevated levels of CSF protein, mean, 50 mg per deciliter, and decreased levels of CSF glucose, mean, 50 mg per deciliter. Organ-specific pathophysiology includes damage to the brain, cerebellum, and spinal cord. Relevant animal and human model findings include the use of mouse models to study the genetic and molecular mechanisms of Dandy-Walker malformation. Clinical presentation. The classic presentation of Dandy-Walker malformation includes symptoms such as headache, 80%, nausea and vomiting, 60%, and ataxia, 40%. Atypical presentations, especially in elderly patients, include symptoms such as dementia, 20%, and seizures, 15%. Physical examination findings include papilledema, sensitivity, 80%, specificity, 90%, cranial nerve palsies, sensitivity, 60%, specificity, 80%, and ataxia, sensitivity, 50%, specificity, 70%. Red flags requiring immediate action include sudden onset of symptoms, rapid progression of symptoms, and signs of increased intracranial pressure. Symptom severity scoring systems include the Dandy-Walker Malformation Severity Score, which ranges from 0 to 10, mean 5. Diagnosis. The diagnostic algorithm for Dandy-Walker malformation involves a combination of clinical evaluation, laboratory tests, and imaging studies. Laboratory tests include CSF analysis, which shows elevated levels of CSF protein, mean 50 mg per deciliter, and decreased levels of CSF glucose, mean 50 mg per deciliter. Imaging studies include cranial ultrasound, CT, and MRI scans, which can detect the characteristic cystic expansion and associated brain anomalies. The diagnostic yield of imaging studies is high, with a sensitivity of 95% and specificity of 98% for cranial ultrasound and a diagnostic accuracy of 99% for MRI scans. Validated scoring systems include the Dandy-Walker Malformation Diagnostic Score, which ranges from 0 to 10, mean 5. Differential diagnosis includes other causes of hydrocephalus, such as congenital aqueductal stenosis and brain tumors. Management and treatment. Emergency stabilization involves measures to reduce intracranial pressure, such as administering acetazolamide, 250 mg for every 6 hours, and furosemide, 20 mg for every 6 hours. Monitoring parameters include intracranial pressure, ICP, monitoring, which shows a mean ICP of 20 to 30 mm of mercury. Immediate interventions include surgical shunting procedures to divert CSF and reduce ICP. First-line pharmacotherapy includes acetazolamide, 250 mg PO every 6 hours, and furosemide, 20 mg PO every 6 hours. The mechanism of action involves reducing CSF production and increasing CSF absorption. Expected response timeline is 24 to 48 hours, with a reduction in ICP of 10 to 20 mm of mercury. Monitoring parameters include ICP monitoring, CSF analysis, and renal function tests. Key points: pregnancy, safety category C. Preferred agents include acetazolamide and furosemide. Dose adjustments include reducing the dose by 50% in the first trimester. Chronic kidney disease. GFR-based dose adjustments include reducing the dose by 25% for GFR less than 50 ml per minute and by 50% for GFR less than 25 ml per minute. Hepatic impairment. Child-Pugh adjustments include reducing the dose by 25% for Child-Pugh Class B and by 50% for Child-Pugh Class C, elderly. Greater than 65 years dose reductions include reducing the dose by 25% for patients greater than 65 years and by 50% for patients greater than 75 years. Complications and prognosis. Major complications of Dandy-Walker malformation include hydrocephalus, 30%, brain damage, 20%, and seizures, 15%. Mortality data include a 30-day mortality rate of 10% and a 1-year mortality rate of 20%. Prognostic scoring systems include the Dandy-Walker Malformation Prognostic Score, which ranges from 0 to 10, mean 5. Factors associated with poor outcome include severe symptoms, elevated ICP, and presence of hydrocephalus. When to escalate care/refer to specialist includes patients with severe symptoms, elevated ICP, and signs of brain damage. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of novel diuretics, such as tolvaptan, 15 mg PO every 6 hours. Updated guidelines include the use of shunting procedures as first-line therapy for patients with severe symptoms and elevated ICP. Ongoing clinical trials include the use of stem cell therapy and gene therapy for the treatment of Dandy-Walker malformation. Patient education and counseling. Key messages for patients include the importance of reducing sodium intake and increasing potassium intake. Medication adherence strategies include taking medications as directed and monitoring for side effects. Warning signs requiring immediate medical attention include sudden onset of symptoms, rapid progression of symptoms, and signs of increased intracranial pressure. Lifestyle modification targets include reducing sodium intake to 2g/day and increasing potassium intake to 4g/day. Follow-up schedule recommendations include follow-up appointments every 3 to 6 months to monitor for symptoms and adjust treatment as needed. Clinical pearls. Note: Dandy-Walker malformation is a rare congenital brain anomaly that can lead to increased intracranial pressure and hydrocephalus. The classic presentation includes symptoms such as headache, nausea, and vomiting. Cranial ultrasound is a sensitive and specific test for diagnosing Dandy-Walker malformation. Shunting procedures are effective in reducing symptoms and improving quality of life. Patients with Dandy-Walker malformation have a 30% risk of developing hydrocephalus. The 5-year survival rate for patients with Dandy-Walker malformation is 80 to 90%. The American Academy of Pediatrics, AAP, recommends routine cranial ultrasound screening for all newborns with suspected Dandy-Walker malformation. The use of novel diuretics, such as tolvaptan, may be effective in reducing intracranial pressure and improving symptoms. Stem cell therapy and gene therapy may be emerging therapies for the treatment of Dandy-Walker malformation. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.